Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. What better way to start off 2026 than talking about the BOC?
You know what? This is the year that some of you guys are going to pass your BOC.
That's pretty crazy to think about, actually. Like, to put it in perspective for someone like that, like, that's pretty nuts.
If you're already past the BOC and well into your career, just think about, could you imagine if you woke up the year that you were going to pass and just think, like, this is the year that I'm going to pass my BOC?
I know, that's funny, because, like, going through it, I never thought of it, like, that way. But now that you kind of put it that way, it's like, man, that was pretty cool. But now, also, I'm kind of, like, glad I don't ever have to do that again.
What do you mean? That's an option.
It is an option for CEUs. You don't have to do CEUs. You could just retake the BOC each reporting cycle.
I don't know why you wouldn't.
Mm-hmm.
Just kidding.
Yeah, I'm good.
I would much rather learn new things. But speaking of, so you don't have to study alone for the BOC. We're putting together these BOC IRL episodes, which are, if you haven't been here before, they're basically what you would find on the exam, but in real life. Mm-hmm. So obviously studying from a book is, it's studying from a book, but gathering stories from people about these actual topics and kind of like synthesizing them and bringing them together. And it kind of adds a new element of like bridging that gap between education and experience. And that's really what we're here to do on AT Corner.
Yeah, it gives the real world application of what the book is telling us.
Yeah, so today we're going to talk about pharmacology. Again, this is just we're not a BOC study guide at all, but we are sponsored by someone who is. So this episode is brought to you by ATStudy Buddy. They are actually way more in depth. Mm-hmm. They have practice quizzes, full length practice exams, domain specific tests. You can go specifically by pharmacology or by other things. And they have modules for each topic. They have games that are dragging the words, vocab words, or to parts of the body, or whatever topic you're on. They actually have games like word searches or some other fun things that are not just studying from a book. So we're super excited to be working with them. And you can actually use code ATCornerStudent for 10% off your monthly subscription price. And that will all be in the show notes below. And then throughout the episode, we're going to also share some example quiz questions thanks to them. So why don't we get started in the basics of pharmacology? Again, there's so much that we could have put in this episode. I sat for the last month trying to just figure out what we were going to piece together. I was, there's so much you can do with pharmacology, but I think, again, this is an overview, basics, what we can start with. But I think some of the foundational things that we can talk about first are the difference between pharmacokinetics and pharmacodynamics. Mm-hmm. So pharmacokinetics is what the body actually does to the drug itself. So absorption, distribution, metabolism, excretion, and then pharmacodynamics is what the drug does to the body. So it's an inverse. Yeah. So pharmacodynamics, dynamics is a D. So what the drug does to the body.
Yeah. Oh, I like that.
And then, so basically that's the mechanism of action. So is it going to be binding to receptors? Is it going to be blocking enzymes? An antihistamine is going to block the histamine receptors, so then you're not going to have allergy symptoms. So that's how that process works. Same thing mechanism of injury, how the injury happens, mechanism of action, how the drug does its job. And again, that's within the pharmacodynamics.
Yes.
For pharmacokinetics, those 4 that I mentioned earlier, starting with absorption. So this is how the drug moves into the bloodstream. This is really important to think of when you're talking about exercise, because basically if you are exercising strenuously, think about how you don't get blood flow to your GI tract, but a lot of medications are oral administration.
Yeah.
So that so any oral absorption of that drug is actually going to be slowed down because that blood flow is shunted away from that area. So continuing with that exercise example where the blood flow is shunted away from the GI tract, it's actually going toward the muscles and the skin.
Mm-hmm.
So any subcutaneous or intramuscular absorptions are actually faster.
See, I think that when I was reading that, and it makes sense, it's a good thing to remember, like, especially the people that are big Voltaren gel people.
Mm-hmm.
Like, you could apply this and then do your rehab. And now you're getting the medication into the site a little bit faster through the skin. Also, too, that can also work with ultrasound. I know evidence on phonophoresis itself is a little limited, but if you're doing ultrasound on with the goal of deep heat, you could do the ultrasound first, heat the area, open basically the pores of the skin, and then apply your med too. That can also work.
These are all things to keep into consideration, like when someone is like about to take a medication, or think about like also food decreases the absorption rate because when you're eating it takes longer for the food to get out of the stomach.
That's interesting. That's good to know.
So if a medication says like take with food or don't take with food, like sometimes it has to do with like the acids in your stomach, or sometimes it has to do with like the absorption rate. So something to really pay attention to.
That's a good refresher.
Yeah.
That's perfect.
So distribution is the movement of the drug throughout the body to like the different areas of where it needs to go. This is going to be important when we talk about the asthma drugs, which will be coming up. Metabolism is when the enzymes chemically alter that drug. Usually this is in the liver, and that's called the first pass effect, where the drugs go through the liver, and actually a lot of the drug is actually deactivated by the liver, and then the rest of it is what is doing its thing. So basically the dosages have to account for this, because like the liver is going to be like, no, you can't do this.
Nah, dog.
Yeah. So if they just give them what like your body actually needs,
Yeah, they're giving the higher dose to account for most of it not getting through.
Right, exactly. And then excretion is removal of the drug from the body, most often through the kidney, and excreted out. Just a couple more like basic vocab things before we get into the nitty-gritty. Administering versus dispensing is probably one of the most important things, and I feel like most people probably already understand it, but I did want to go over it. Administering drugs is basically giving out a drug that is going to be taken within 24 hours.
Okay.
So I asked on our Instagram questions for the story episode if the people in our following give out over-the-counter drugs. And it was actually pretty close within, we had a couple hundred votes, and 51% said yes and 49% said no, which was really cool. I have only been at a few places that have given out over-the-counter drugs, but honestly, because of all the documentation, we just kind of say, you know what, someone else has.
Yeah.
Like one of your teammates probably has it, or like you can get it. So like you can have it. Like we're not going to pay for that. And when you can get it somewhere else.
Yeah. I do. I give out OTCs just because I want them to like come to me with that stuff.
That makes sense.
That's why. Because you're right, they can get it from a teammate. And that's why like visiting teams I won't. So like if a visiting team asks me, hey, do you have meds? I'm like, nah, dog. That one, you can get it from your teammate. But for my kids, I'd rather kind of know what's going on instead of them just doing it on their own.
Well, I mean, they still
probably will, but if I say no.
And then when someone says like, do you have Tylenol? Do you have Advil? Usually it's like, do you have ibuprofen?
Yeah.
I don't say no. I say why.
Yeah. Well, yeah, that's why I'm always like.
Because if you say no, then they're not going to tell you anything.
Yeah. I'm like, what's it for? But yeah, no, I do keep record of each one given.
Nice.
Yeah.
What do you include in it?
The name of the person, what medication, the expiration date of the medication, and then what lot number
Nice.
is that coming from? Because we have the
little-
bag ones, the little packets.
Dose packs.
Yeah.
So according to the consensus statement, NATA consensus statement, information on the log sheet should include the patient's name, injury or illness, medication given, dose, quantity, lot number, and date administered or dispensed.
Yeah, I got those ones.
So, most people actually didn't write injury/illness. Like when I was getting answers of like what people kept in their log. So like, this one's really good. This anonymous one says, we give out ibuprofen, acetaminophen, decongestant, and antidiarrheal, Tums as well. We keep all of ours in a locked cabinet in the ATR and have a medication log filled out whenever one is taken. It includes the athlete name, sport, dose, quantity, indication, manufacturer, lot number, expiration date, name of dispenser, and the date dispensed. That's pretty elaborate.
Yeah, that is. I do need to do the injury illness one too. I need to put that in. I need to update my sheet.
We basically have a log, because we just don't give out like your state, like we give out like Tums and and like electrolytes and antidiarrheal, like stuff like that. We just don't give out like pain medication.
Yeah.
But those, like, we just have a log that just like, it looks like an Excel sheet, and it's just kind of like one line. Technically, you are supposed to transfer it to the patient's own chart.
Yeah, like your EMR.
The other option, other than administering, is dispensing. So dispensing drugs, think of it like a dispenser, because a dispenser is like multiple. That's the amount of medication to be consumed by the patient over a period of time. So like over 24 hours. So just a unit dose pack is administering, but like grabbing a handful of those and handing those out is like you're a dispenser, like a gum dispenser. Also, all drugs must be locked in a secure cabinet. A study in 2006 in Journal of Athletic Training said that 55% of athletic trainers stored medications in a locked cabinet, compared to 67.1% in 2001.
I think the one thing to remember as well with that is because like everywhere I've been, we've done that. We've made sure it's in a locked cabinet. In mine, it's a locked cabinet. But another thing that's kind of a technicality is your med kit.
Okay, I was wondering about that too, because I mean, technically my med kit is in a locked.
Oh, so then yours would be good.
Yeah.
But there's a lot of places, right? Like their med kit's just in their office, and like if you do, I mean, maybe if you don't carry meds, then it's not a problem. But like if you do carry those meds, I mean, technically that's not a locked cabinet.
So we did a very small survey of this in our broadcast channel, which is new for us, but it's basically like a message that we send out to everyone on our broadcast channel when we put up posts for an upcoming story episode, so then you don't miss the posts in our Instagram stories. And so we put a very small survey together, and it looks like most people actually don't have medications of that group. And if they do keep them in a locked cabinet. Some people keep them in the office or their med kit, like you were saying.
Yeah.
I also asked what medication you see prescribed most often in your athletes, and by far it was meloxicam.
Oh, interesting.
Which that would have been my answer, is meloxicam is what I see the most. Which is an if you've never heard of it, is a NSAID.
Yeah, no, I haven't heard that one.
Really?
Yeah, most of mine. I mean, I don't think my athletes get prescribed meds that much anymore. But
really,
originally it was our ortho really liked Toradol and Naproxen.
Oh,
big fan of that one.
I've never had a doc who's given Naproxen.
And then every now and then he'd throw in a prednisone. Yeah.
So we're gonna go over all these like suffixes and then and these names, and you like, if you re-listen to this part, you're gonna be like, oh, I know what that is now. Another high one was diclofenac or Voltaren, which I'm seeing a lot more now.
Well, it's also because Voltaren at certain dosages now is over the counter. So that's nice, because it was hard to get when it was a prescription. Yes.
So the Voltaren I'm seeing a lot. Other high answers are naproxen, prednisone, and Toradol. And that's kind of mostly what we got.
Yeah.
Okay, so now we're going to get into the different types of medications. I'm starting with antibiotics. We're also going to do antifungal, anti-inflammatory, analgesics, CNS depressants, asthma therapy, antihistamines, GI drugs. There are so many more. Like, I didn't even start to touch on diabetes drugs or steroids, which I wish I could, but I don't think we're going to have time. But anyway, let's just get started. Antibiotics are obviously drugs to treat bacterial infections, and these usually end with "in." Now, when I say that these have a suffix, like, not every single one is going to end with that. So, like, there are going to be ones that don't fit the rule. Surprisingly, antibiotics are actually the most frequently prescribed drug.
Yes.
Usually, it's like 7 to 14 days of treatment. I think everyone knows this, but discontinuing antibiotics can cause a superinfection. Most side effects of antibiotics are diarrhea. Think about like the microbiome, antibiotic.
Yeah.
So antibiome, like it's messing with the gut microbiome. Examples of these are going to be like your penicillins.
The OG.
Yeah, exactly. The cephalosporins, carbapenems, tetracycline. So like doxycycline, minocycline. I don't know if I'm saying those right. Macrolides, the sulfa drugs. So like sulfonamides, which is, think like on a physical when people are like, oh, do you have any drug allergies? I'm allergic to sulfa drugs. It's antibiotics.
That's good to know. I wasn't 100% sure. I'd always have to look.
Honestly, I didn't actually really, I just kind of took it at face value.
Yeah.
I don't think I ever really thought about it. But now, sulfa drugs, antibiotics. Aminoglycosides. Okay, this one is probably the most important to remember. The fluoroquinolones. And these are things like ciprofloxacin. These are antibiotics that they have a potential to cause like tendinitis or tendon ruptures, which is obviously dangerous if you're in sport. So I know that we've both had team docs that anytime someone's on antibiotics, we always get the name of it. So then we can figure out like, oh, is it Cipro? Or is it within that family? Because we have to take extra precautions if they're on those.
Yeah.
And a lot of times they're prescribed preventatively. So just that education piece and, can we use a different antibiotic or do we have to take this? What are the cons of not taking this? Or, just having that little education piece.
Yeah, Cipro is a pretty common one that tends to get prescribed. We used to, if we ever had someone prescribed Cipro, we would run it by our team doc first before they returned to play to be like, hey, are they good? What do we need to watch out for?
Did your team doc ever have any sort of like, was it like a time frame or was it like criteria or like what?
It was mostly just keep an eye on them. Just start noticing if they start having like tendon pain.
Okay. Did you have anyone?
And we would try to progress them a little bit slower.
Okay.
Yeah.
Did you have anyone who had?
No, we never had. I mean, we did a pretty good job of trying to stay ahead of it.
Okay, that's
and
good.
Communicate with our health center, but every now and then the health center would just, here's some Cipro. And then that would throw a major curveball for us.
A couple of topical antibacterial drugs. I'm sure you've heard of bacitracin, like bacitracin zinc, neomycin, polymycin. So again, that tetracycline, clindamycin or erythromycin. Clindamycin is I think it's for acne. So that might be something that people might be using that's like topical. Bacitracin is like wounds. So all of these that I shared, actually, I think all of those. Oh, except for the sulfas. Yeah. Most of them end in.
Yes.
And then the antifungal drugs are going to end in like OLE. So like these are drugs that treat fungal infections, obviously. So ketoconazole, fluconazole, itraconazole, voriconazole, posaconazole. There are so many more. Some of these will be like, I've had some of these for eczema. So like the first one, ketoconazole, whatever, however you say that. That one I've used. And I've seen other athletes with eczema being treated for it.
That's interesting. I didn't know that.
Not just like a fungal infection itself, but they can be used for eczema.
Also, keep in mind some of these anti-fungals are over the counter. So you'll see this a lot with like athletes with athlete's foot, right? Mm-hmm. Like I always blank on the brand names, but there's like Tinactin. Mm-hmm. There's another one I can't remember now. But like those ones, like usually, like if you have someone with athlete's foot, you just have to let them know, because like you're not probably going to order this and just keep it, because like athlete's foot, it's not super. Well, at least I haven't. I've only had maybe an athlete here and there.
If someone has an athlete's foot, I'm probably just going to send them to urgent care.
Yeah, exactly. Or I'm just going to literally tell them, hey, do this. And most of the time, from what I've seen on those, it's usually like a twice a day kind of treatment. You have to like twice a day rub it on.
Yeah.
I think for each time I've looked, I think that's usually what the recommended dosage is.
Mm-hmm. Okay, now we're getting into the fun part, anti-inflammatory drugs, and these are drugs to treat inflammation. So inflammation's usually treated with two types of drugs, either NSAIDs, so the non-steroidal anti-inflammatory drugs, or corticosteroids. So basically steroids or non-steroids. Yeah. These are great for pain and inflammation, but they're poor for gut health. So you got to make sure to take these with food. Examples of NSAIDs are aspirin, diclofenac or Voltaren, ibuprofen or Advil, meloxicam or naproxen sodium, which is Aleve. Starting with aspirin, you'll also see it as ASA or acetyl salicylic acid.
Say that 10 times fast.
Which also you'll see like salicylic acid as like a topical. Like I've seen salicylic acid like topically.
Oh yeah, you're right.
So
never thought of that.
I think it has to. I think aspirin is known as that too. So don't quote me on that, but look that up. It's usually in a 325 milligrams, but it's also available in 81 milligram, which is so specific because usually they're like. Yeah, but 81 is the it has to do with like when they made the dosages like a long time ago, and I don't know. But anyway, it's a smaller dose, and it's usually referred to baby aspirin, which is such false advertising because you actually cannot give it to anyone under the age of 19 because of a potentially fatal Ray's syndrome, which is vomiting, lethargy, confusion, liver, brain damage, etc. following a viral infection such as like chicken pox or the flu. So even though it says baby aspirin, like literally think opposite. You cannot give it to a baby.
Oh, what's funny with aspirin is like no one ever asked for that. I think I've heard someone say it one time, or someone asked me one time, and I feel like that's like a older person thing. So when they were like,
it's one of the oldest medications.
Yeah. So when I had someone ask about aspirin, I was like, "What do you like? What?"
So I actually had someone who was taking aspirin instead of something else. Like I think that it's so surprising actually how much like the general population does not know about pharmacology. I think because we're around this, we're just like, oh, like we know the difference between ibuprofen and Tylenol, but I think you just don't realize that people don't. And so like this kid just had a bottle of aspirin and was like taking it, and I was like, what are you doing? Like, what's your goal with that?
Yeah. Well, also too, I think another problem is now that we're starting to get into drugs that we're starting to see used a little bit more and more often. People have a hard time with generic name and probably brand name.
Yeah.
You know?
Yes.
Like Motrin technically was the OG ibuprofen. Mm-hmm. So when someone asks for Motrin, if they're going to ask, can I have Motrin or Advil? It's like, dog, it's the same thing.
Right.
So I think that too can confuse it.
Yeah. So speaking of Advil or ibuprofen or whatever you want to call it, typically these are 400 to 800 milligrams, so a lot different than your 325 or 81 aspirin. In one day, you can take up to 1,200 over the counter, but prescription, you can take up to 3,200. So that's 4 of those big boys.
And I think what people need to remember for ibuprofen to be anti-inflammatory, it does need the higher doses. So like people that are just going to take like a 200 milligram or 400 milligram and think, oh, this is anti-inflammatory. Unfortunately, it's going to be great for your pain. It's going to help with the pain aspect of it, but it's really not going to give you the anti-inflammatory effect.
Right. And then a lot of people actually choose naproxen sodium, which is a Aleve, instead because it's a 200 to 500 dose and you only have to take it twice a day to get the maximum dosage. So it's a lot easier than taking like so many pills.
Yeah. And I believe it's supposed to be longer lasting, at least pain wise.
I think so.
Yeah.
So moving into corticosteroids, these end with "-one", like cortisone, hydrocortisone, dexamethasone, prednisone, triamcinolone. These actually suppress the inflammatory and immune responses. This is important because immune responses often trigger inflammation, and this is because of their histamine release, right?
Yes, yeah.
So usually you'll see things in like arthritis, asthma, like all these have like an immune part of it, right? Asthma, inflammatory bowel disease, think of all that inflammation, inflammatory, tendinitis because of inflammation, bursitis, allergic reactions, dermatological conditions like eczema, so like hydrocortisone. Actually, usually that's not, but anyway. Emily M says, I have to teach almost everyone that you're supposed to tap in hydrocortisone cream and let it finish absorbing. I had a patient at my last school with a rash on the bottom of her foot from the arch tape we were doing, spray, coverall, moleskin, and it spread up her other leg, but we tried stopping the tape job and that didn't go very well. Thankfully, a few changes helped, as well as hydrocortisone cream and socks and sweats to bed.
Nice.
Hydrocortisone can also be used for itching from insect bites or also contact dermatitis, so like poison ivy, etc. But again, it's not meant to moisturize. It's meant to stop that itchiness response. So I think some people also like, you got to remember what it's actually used for. And again, it's a corticosteroid. So it's going to suppress that inflammatory immune response. It's like, that's what it's made for.
Yeah.
And again, like Emily goes over that she has to like tell everyone how to properly use it because again, like not everyone knows how to use these things, and it's a topical, so it needs to be able to get into the bloodstream.
Yes.
So you do need to finish letting it absorb.
Yes. Yeah, exactly.
Any cortisone dose is actually going to be the lowest dose and the shortest amount of time. Even like hydrocortisone, because corticosteroids can cause adrenal suppression because corticosteroids are produced in the adrenal gland.
Nice. Okay. That's good to know.
I also asked on our Instagram stories if you've ever had an athlete who's gotten an injection, and I was actually surprised that it was not almost everyone. 83% of people said yes, and 17% of people actually said no. And I was actually wondering, maybe some high school or like younger.
Yeah, they may not be doing it for...
I mean, I have had some high school athletes who have gotten injections before. I'm hoping it's not as common, but you know.
Yeah.
Who knows?
I mean, even then, now, I don't see a lot of anti-inflammatory injections. I think I've maybe personally seen out of my athletes one that got cortisone.
Really?
Yeah. And he did a little too much when he was told not to.
Oh.
And that didn't go well for him.
I feel like I see a lot of cortisone in like toe or arch.
Yeah, and that's what it was. It was actually for plantar fascia pain.
Oh, okay.
Yeah, so that's what it was. Now I see a little bit more PRP.
You know what? Actually, Kjersten M said cortisone occasionally, but we're seeing PRP more often.
Yeah.
And then she also said for PRP, we follow the UW protocol.
Oh, that's interesting. I'll have to look that.
Which I did look up. I think it's super helpful. It has like rehab goals, progression criteria, suggested exercises. Dope. I know. So I really liked that. Honestly, usually when I get someone who has PRP, they kind of come with their own, like, I mean, our docs just kind of give them their own protocol. But I do like that if someone came without like a formal thing, like it kind of gives me like a
direction,
better guidelines.
Yeah, we're really lucky. Our team doc, he really likes it, and most time he's just like, "I'll just do it. Don't worry about it."
That's nice.
Yeah, because that is the drawback with PRP is it's just not covered yet. So
they're like $850 to $1,000.
So
like,
there's times he's just like, I really think this would work. I'll do it. I mean, he also is like, it's his own practice, so it's like,
that's nice.
He's kind of the boss.
That's nice. Sarah Y says, we do injections in clinic all the time. We do them anything from sinus tarsi syndrome to bursa injections. The only thing we won't inject is the spine. We also start doing hydrodissections on Achilles and patellar tendons. We use a mix of lidocaine and Kenalog, which is a corticosteroid, for most injections. For the Achilles and patellar tendon hydrodissections, we use saline and a little bit of Kenalog at the end.
Nice.
I don't think I've ever gotten an athlete who's had a hydrodissection.
No, I haven't. No. That's
pretty cool. I had to look it up. I was like, oh, this is cool. Emily M also says PRP, like knee joint, patellar, Achilles tendons, peroneal, post-tib tendon sheaths. You can kind of see like how that follows the areas of like blood flow, tendons, and then corticosteroids, AC joint, knee, coach's shoulder. PRP follow-up depends on location and doc protocol. For me, it's a range from 48-hour rest to a 6-week return. Steroid injections usually is that lidocaine will help for 3 to 4 hours, and then you're going to feel worse again. Could take a few days to a week to have steroid take the actual effect.
Another injection, not an anti-inflammatory, so a little bit not on the topic, but one injection that I had that I was starting to see, but now I don't see it as often, is hyaluronic acid.
Oh, you know what? I have seen that.
I've been seeing that into like some joints, especially like for like chondromalacia or patellofemoral pain. I've seen that, and each athlete I've asked that have had it, they're like, yeah, it feels pretty good. So I'm like, oh, that's cool.
Promising.
So yeah, I think that's been an option for like some joint issues, like cartilage defects and stuff.
Well, we're moving more into analgesics now. So analgesics are drugs to alleviate pain. Opiates and opioids. Opioids are actually like the broader term for drugs similar to opiates. So the actual opiates or like morphine, codeine, but opioids, again, that umbrella term, are going to be like oxycodone. I actually haven't heard of this one, but meroperidine. Oh, it's because it's Demerol. I've heard of Demerol.
Oh yeah, I had heard of Demerol. See,
but I've never heard of meperidine, like the actual like
the generic name.
Hydromorphone, which is Dilaudid. These are also called narcotic analgesics because they make you sleepy to reduce your pain, which is very effective.
Yeah, I mean it is.
Yes. And then also just a note, like narcotic refers to any controlled substance, not just opioids.
Yeah.
I have personally had opioids for kidney stones and they are horrible. I hate the feeling of them. I feel like it felt like I had like a migraine. Yeah. Like I felt like I couldn't like hold up my head and then it would just like knock me out, which was good because then like you're on pain, but I don't know. I don't know of other people's experience, but I know for me, I was not a big fan.
Yeah. And one important thing too is like, obviously we're not like, these are prescription and obviously we're not really like just, hey, here's your Oxycontin, you know? Right. But it is something that we do have to really understand how they work and stuff and be able to educate our patients because our athletes that get surgery, right? They're probably going to be prescribed this.
Also, they make you constipated.
Yes, they do. They do back you up. Fun story though. I had one athlete who had ACL reconstruction and I told him, I was like, all right, they're going to prescribe you like opioids. He was like, oh man, I don't want those. I'm like, I don't know, dude. Like, I think you're going to want to take them. Like, obviously, get off them as soon as you can, but I'm just like, you're not going to feel good. It's like, no, I'll be okay. I'm like, all right, dude. He actually just thugged it out with ibuprofen.
Wow.
He did not take his opioids. I was like, you're an animal.
Wow. Good for him.
Yeah.
Okay, so acetaminophen. This one also has a bunch of names. N-acetyl P-aminophenol, also known as APAP. So you'll see this, I feel like most of the time, like whenever a doc writes anything, they'll say like APAP, which is acetaminophen.
Yeah.
Well, I call it APAP. It's not AP. I mean, it's APAP. I think it's called APAP, right? That's how they say it?
People say APAP.
Okay.
Which, by the way, I think APAP was the original brand name.
Oh, okay. Yeah.
I think Tylenol came later and they just like, they ran with it.
That makes sense. Paracetamol is also a name. So Megan M says, I've had lots of international athletes and had to look up a lot of things. Once had an athlete asking for a certain topical medication after excising a blister/callus on the toe. Turned out it has mercury in it and is banned in 12 countries.
Oh my God.
That was a hard no from our docs and myself. A lot of them are the same, just called something different, like paracetamol, which is
acetaminophen.
Yep. Some are also prescription here, but not overseas, and vice versa. So we always have bigger conversations when dealing with multicultural patients. So I also asked on our Instagram stories what you do when you've had an athlete who has a drug that you've never heard of, because obviously that's going to happen. On our physicals, we actually ask what medications they're currently on, and there's a bunch of things that I always have to look up every year because I'm like, I've never heard of that. Most people say they look it up, and then our second answer, we really only got like two groups of people. It was either people who looked it up or people who said, I'm texting my team doc. So I guess it depends on how close you are to your team doc. But we got, I should probably compile like where people looked up their answers, but a lot of people said Google. Some people said Medscape, which is what I use. Yeah,
I was gonna say that's a really great tool. Medscape's great for looking at meds because it gives you all the information you could want on it,
and even like drug interactions and stuff.
That's the big one, is one drug interaction. So what's it going to interact with? So now I know what it, like, if there's anything that I can't give them.
Whenever I'm prescribed something, I always look it up on Medscape.
Yeah. It also tells you indications. So if you see a med and you're like, I don't know what the hell this is, you can look at like what is it indicated for, and then basically look at their history and be like, oh, so this is like a antidepressant or like something like that. So like it kind of helps give you that quick information. I mean, you could always ask the athlete, but sometimes like they turn in their medical history and they're not there. All right, so you want to try and get a quick idea. It also actually gives you information on the pharmacodynamics and pharmacokinetics.
Oh, that's really cool. Yeah, I don't think I paid attention to that part.
It's pretty, and it gives you dosages too.
Yes. Oh, speaking of dosage for APAP, paracetamol, which is
acetaminophen.
There you go. A normal dose is 325, but extra strength is 500, or even 1,000 sometimes. But you cannot exceed 4,000 per day, which is where you get in trouble because a lot of your like opioids, opiates, like higher strength prescription drugs too have Tylenol in them, or like acetaminophen. So actually, according to I think I found this in the book, The Principles of Pharmacology for Athletic Trainers, is edition, where I found most of the stuff for this episode actually. Most calls to poison control are overdose of acetaminophen because of the interaction in the drugs. So like things will be like hydrocodone plus acetaminophen. Yeah. And then people take Tylenol on top of that.
Yeah. That brings up a good point, is really make sure to pay attention to what opioids your student athletes have been prescribed, because a lot of them aren't just one thing, right? Like I think like hydrocodone or Vicodin, I believe it's
with Tylenol.
Yeah, the brand Vicodin is hydrocodone and Tylenol. I think Oxycontin is oxycodone and like Tylenol or ibuprofen, something like that.
And like you can take just Tylenol and ibuprofen together. So a lot of times people will like do that, and then they'll take they're like, oh, Tylenol, it's like, it's fine, so I can take it with something else. But really you're really overdosing on.
Yeah, so you really want to make sure your athletes do pay attention to
Right.
what they're taking, because I actually ran into that again. Not necessarily like you're going to see this in like athletes, but I had a student athlete had their wisdom teeth taken out, right? And again, you can be prescribed opioids for that, and I can't remember which one she had, but it had, I think, like ibuprofen in it. And she was taking ibuprofen as well because she was still in some pain. So she's like, oh, I'll take ibuprofen. And like, she started having some really weird symptoms. And I was worried she was overdosing on ibuprofen. I mean, I don't think it ended up being that, but I did send her to the ER.
That's a good thing to double check. Another thing about Tylenol is it's an antipyretic, which means it's a fever reducer. It is actually not an NSAID. So it does not cause GI irritation or ulcers, which I think is also why they kind of do this with like opioids.
Yeah.
Because it's mostly centered on that pain relief.
Yeah.
A lot of times when people are like, oh, I have a fever, I'm going to take an ibuprofen. I'm like, dude,
I mean, you can, but
Tylenol is literally a fever reducer.
Yeah.
Also note that many analgesics contain caffeine, which is made to enhance the effect of the analgesic product.
Oh, that's interesting.
But most people actually use caffeine as a CNS stimulant to decrease drowsiness and fatigue, think like your coffee. Sarah Y says, my rugby players come to me all the time in the fall for electrolyte pills and Tums. I also have Midol that I give them for pain medication. These are adults. I also ask them if they have any bleeding disorders where they can't take NSAIDs or a heart condition because of the caffeine.
Yeah. Also too, like migraine medication tends to have caffeine.
Yes.
Yeah.
And that usually works pretty well. Going kind of the opposite direction. So instead of a CNS stimulant like caffeine, we're actually going to go CNS depressants, which are drugs to depress the central nervous system. Antidepressants, anti-anxiety drugs. So these are like your benzodiazepines, Xanax, diazepam, Valium. These are also sedatives. They're super dangerous to combine with alcohol because the sedative effects are enhanced.
Yeah. Also, I would wonder too, because it's a depressant, how it would interact with like opioids.
That's a good point.
Right. So I think if I had, again, this is another situation. Again, we're not like managing these meds, but like say you have an athlete that is on like Xanax and they're going in for surgery, right? That might be something to bring up to the team doc. Be like, hey.
And because these affect CNS function, you also want to be cognizant about like heat illness.
Oh, yes. Yeah, good point. I think, what is it? Antidepressants.
SSRIs.
Yeah. They have a higher susceptibility to like heat illness, right?
Yeah.
And also too, important to know just interactions. Right? What is Xanax and all them going to interact with?
And I think the stigma is getting better, but I still know there are probably some athletes who are on medications that we don't know of, or even like what if they get put on it like mid-year, like after they have their physical. So
they're not going to say anything.
Exactly. They're not going to come to you and be like, I'm taking this new medication, by the way.
Hey, you never know though. Every now and then there might be one because I had one athlete, maybe she did tell me about medications too, but she would update me on her cycle just so I knew. So
the next thing is asthma therapy. So we're finally to the asthma. So these are drugs to treat asthma. There's two categories. There's rescue therapy and there's long-term control. Actually, one of our very first episodes, I think it's actually episode number 2, is about asthma. And so if you want to go a little bit more into that, scroll all the way back. Sorry about the audio quality. It's probably pretty bad.
We were babies.
We were babies. But yeah, we talk a little bit more about, obviously a lot more about asthma in there. I think it's actually a pretty long episode. But anyway, this is, there's rescue therapy, there's long-term control. Rescue therapy is for quick relief of asthma attacks. Most often, these are bronchodilators. I'm just gonna kind of not go into the full physiology of it, because time. But it's really fascinating. Like once you actually like look into it, it's going to be pretty easy to remember because it all makes sense. But basically, this is going to be a short-acting beta-2 agonist and anticholinergic drugs. An example of this is albuterol, which is also called salbutamol. You can also have a corticosteroid if needed for severe symptoms. And remember, we talked about corticosteroid being for immune and inflammatory.
Yeah.
So this corticosteroid is going to help like bring that down. For long-term control, it's going to reduce the occurrence of the acute attacks. So if you notice someone's having like more like acute attacks more often, obviously that means you should probably send them back to their physician to re-up their, or like take a look at their long-term control and see if they can review that medication. Things like Symbicort, which is a I don't know if I'm going to say this right, budesonide, and formoterol. Formoterol.
That's what I would say.
So remember, IDE is a corticosteroid. So the budesonide is a corticosteroid. And then the formoterol is a long-acting beta-2 agonist.
Yeah.
And think like formoterol kind of sounds like albuterol, kind of sounds like salbutamol. So there's your beta-2 agonist.
And when you talk about long-term control, like you said, if you're starting to get more asthma attacks, or if they're starting to have difficulties in the evening, right? That was an important history question we would always ask, is especially someone who's like kind of noticing that like, hey, I'm having some issues. Like, are you waking up out of breath? Right? Are you waking? That was a big one for us, was, are you waking up feeling like you're out of breath? Are you waking up, you feel like can't breathe and stuff like that?
Yeah, that's a good history question to ask. Remember that asthma is a chronic inflammatory condition of the airways, so that's why that corticosteroid is going to be so important. Most asthma drugs are actually administered by inhalation, which is considered topical. The reason why it's topical is because mucous membranes are considered topical, and the drug goes directly to the mucous membranes.
Yeah, that's crazy. That's funny that's topical.
Okay, right? I was thinking that's funny. Because I guess oral absorption would be like through the stomach. Yeah. Right?
You're going through the mouth to the stomach.
Right. Whereas like inevitably you do get some, but you're not trying to do that. You're trying to inhale it.
Yeah. Well, and that's why I think, isn't it best practice to have a spacer?
That's why you have a spacer.
Yeah.
Because even if you do it 100% correct, only about 20% of that medication is actually getting to that lung.
Yeah.
And it's most commonly delivered using an MDI, which stands for metered dose inhaler, which controls how much drug is released during each use. So you don't have to like measure out, or like it's already like, here you go, here's your dose.
I wonder how that was before those were invented.
Yeah, that's a good question.
But yeah, I like how spacer is the best practice, but I've never seen an athlete ever use a spacer.
Okay. Antihistamines. These are drugs for treating allergies. There are two generations of antihistamines. First generation antihistamines are things like Benadryl, which is also, the generic name is diphenhydramine.
Yeah.
The second generation antihistamine is loratadine, like Claritin, Allegra, Zyrtec. And the reason why these are second generation, well, I think just they came second, but they they don't as easily cross the blood-brain barrier, so they actually won't knock you out.
Yeah.
Whereas like Benadryl, like you're done, you're drowsy. It gets to your brain. And actually, I was kind of surprised that, like, I feel like Benadryls have been around for a very long time. And I feel like I mean, and so have the second generation, but I feel like just recently has it kind of been like, hey guys, stop using the first generation.
Well, I think now seeing the long-term use of the first generation antihistamines. I think they're starting to see like, oh, well, the long-term use having some negative effects.
Yeah, that's true. But I was super excited that we got a story about this. So Kjersten M says, I've stopped recommending diphenhydramine due to the large push from allergists to recommend use of second generation antihistamines. This is, of course, if there's no plan in place from a doctor prescribing the use of Benadryl.
Yeah.
Which obviously, like, they're still around for a reason. And I don't think there's harm in, like,
small... acute use.
Acute use. I think it's mostly, like, that long-term use.
If you're, like, just popping them like candy
all the time,
that might be a problem. Mm-hmm. I mean, granted, probably with any med, if you're popping them long-term, unless it's actually a long-term med, probably isn't great.
I'm going to do 2 quick ATStudy Buddy checks before we finish off with a fun little GI, mostly Tums. So ATStudy Buddy check, we're going to give 2 example questions that you would see in, like, for example, one of those longer term BOC exams. So the question they asked is, to prevent the feeling of sedation during the day while taking medications for allergic rhinitis, the athletic trainer should suggest the athlete not to take which medications until he or she is ready to go to bed. So we have expectorants, we have antihistamines, decongestants, NSAIDs, and antipyretic agents. So again, we're trying to prevent the feeling of sedation during the day. So which one should we take? Which one should we wait until bedtime to take, basically? Or wait until nap time?
I tell them don't take the antihistamine.
Yeah, so that's correct. Yeah. Well, and also if we think about first generation versus second generation, so first generation is more likely to make you sleepy and drowsy, right? Yeah. Second generation doesn't as easily cross the blood-brain barrier, so it's probably not going to do that. Expectorants, that has to do with like coughing and mucus, so that doesn't. We're not doing that for allergic rhinitis.
Yeah.
Decongestants, maybe, but specifically talking about like the drowsiness.
Yeah.
Antihistamines better fits that category.
Yeah.
NSAIDs, you're not really going to do much for allergic rhinitis. Like, it's not going to do much for your runny nose. Like, it might help with your pain.
Yeah. Yeah.
And then antipyretic agents, again, are for fever reducers.
Yeah.
So
not only, hopefully the students driving to site didn't start panicking because of the question. Like, oh my gosh, BOC question.
Here's another one.
But yeah, this is another important thing about why pharmacology is so important is like a lot of like cold medication, right? Like the main brands like NyQuil, right? They have multiple meds in there and you have to understand what each one is because one of them in there is an antihistamine because it is meant to make you feel drowsy and help you sleep better.
Oh, yeah.
So you don't want to have an athlete popping NyQuil at like noon.
Right. So this one might need some process of elimination. Again, if you don't know the answer right away, looking through the different answers and knowing what you know and figuring out what you don't is helpful to figuring out. So this one says, a wrestler comes to the athletic training facility inquiring about a drug that will make him lose weight quickly.
Oh, no.
Mentioning a diuretic. Which drugs have been banned by the International Olympic Committee that are diuretics? Now, we didn't talk about any banned drugs by the International Olympic Committee, but we can talk about diuretics. So furosemide, we haven't talked about. Ide, I don't think did we talk about anything that ended with ide? We talked about things that end with in.
Yeah.
And we've talked about things that end with ol.
I don't think we're talking about ides.
So, okay, so we don't really have too much information right off the bat of what that is, right off the top of our heads. If you don't know what that is already. Salbutamol, that sounds familiar.
Yep, talked about that.
What is salbutamol? It sounds like albuterol, which is an asthma drug.
Yep.
Okay, I don't think an asthma drug is going to have anything to do with a diuretic. So I don't think we really need to do that. Caffeine, which is less than 12 mcg over milliliters. What is that, micrograms?
Yeah, I think it's
So okay, caffeine is a diuretic.
Yeah.
But less than 12 units. That sounds pretty low.
Yeah.
I mean, if you think about like caffeine's usually like what, like coffee is like 200 milligrams or something like that?
Yeah, something like that, yeah.
So I feel like that's pretty low for caffeine. And then the next answer is none of the above. Well, furosemide maybe is the closest answer. It's either that or none of the above.
Yeah.
So again, we have a 50% chance, and whichever one you feel more comfortable with. But the answer actually is furosemide, and that is a diuretic that is banned by the IOC.
Also, in clinical practice, you can always look up what the banned lists are. Like they don't, for the most part, they don't say each drug that's banned. They have categories of banned drugs. So you basically use that and go from there. And if you ever have a question, you will be asking your governing body about a med, or they'll usually let you know, like, hey, yeah, this is a banned substance.
So lastly, I have GI drugs, and I didn't really go too much in the GI drugs. The most common that you're going to see like in the athletic training facility are like Diamode, or loperamide, which is antidiarrheal. You'll also see Tums. Tums or Alkalac or calcium carbonate. These are antacids, which actually have a bunch of different things in it, including calcium, which actually was so interesting because Sadie S reached out and said, we use Tums for muscle cramps. I've never heard of this while I was in school, but my first head athletic trainer at a secondary school gave me that little tip. It works great. We give 2 to 3 tablets with water and Gatorade when they start to tighten up, and they'll normally make it through the rest of their game or practice. And they like it much better than mustard or pickle juice. And that with a higher combo of a higher sodium drink is gold. So actually I looked up what's in Tums themselves. It's got 1,000 milligrams of calcium carbonate, 410 milligrams of elemental calcium, 5 milligrams of magnesium, and 2 milligrams of sodium, which makes sense because your electrolytes are going to have sodium, potassium, calcium, magnesium. So really, I didn't realize how similar Tums actually have to electrolytes. So that's a fun little tip. I might have to try it now.
Yeah, well, and physiologically, I'm just thinking, I wonder if the calcium carbonate helps with the acidity within the,
which is a good point, because even when you talk about like swishing vinegar in your mouth for cramps.
Yeah. Oh, I haven't heard that one.
Oh, really?
Yeah.
Yeah, you don't even have to swallow it. You just have to, like, that's why pickle juice works.
Wow.
Yeah.
That's pretty cool.
Yeah.
But yeah, that's the only thing I can think of, or at least not only thing, but physiologically why I think a lot of people, because I've heard a lot of people like doing that, the Tums trick. So I wonder if that's why.
Oh, really? You've heard a lot of people do that? Oh, you know what? I forgot. I did ask one more question. Have you ever had an athlete abusing steroids? 12% of people said yes.
Ooh, that's interesting.
88% of people said no. I've actually had someone who has.
Really?
Mm-hmm.
That's interesting. I mean, I never noticed anything that would make me suspicious of it.
Yeah. So I asked how people knew. Maddie E said yes, they were talking about side effects and complications openly. I work in the high school setting, so I had to report this athlete. The written report went to the AD, and he took it from there, making a report to the CHSAA. It's a lot easier on the AT in the secondary school setting for situations like this. Kjersten M said, so much aggression. I was young and didn't really understand how to go about addressing it in the Division 3 when he didn't see the field much, which can be so tough.
Yeah.
Honestly, I didn't notice until after someone told me, and then I was like, oh, all those things line up.
Yeah.
But this anonymous person said they had an increase in muscle strains, So grade 2 hamstring on each side and a history of hip flexor avulsion all within a year. He gained about 60 pounds in 8 months. Coaches and I did address our concerns with the parents and it wasn't received. Dad was an old IFBB competitor that never turned pro. Mom shrugged us off and said, I have no idea what he's giving him, but it's all protein shakes and stuff. Yeah, ours was increase of muscle strains and an increase of weight.
I think another thing too, another thing that makes you wary is when you start seeing like avulsions like that, like really tendons that tend to be really thick, like a pec avulsion, that's a pretty strong tendon. Like not saying it can't happen, but like it just makes you suspicious.
Right.
Also too, another important thing to remember with anabolic steroids these are controlled substances. These are prescription. So like there is some legal ramifications of someone who's not using them in a prescribed manner. Yeah.
So again, if you are interested in more fun ways to study for the BOC, check out ATStudy Buddy. I think you guys will really like it. We got a trial run. And honestly, like we had fun doing it.
Yeah, it was really cool.
When we don't have to sit here studying. So,
maybe that's what made it fun.
Maybe. But again, those interactive games really make it a lot of fun. And there's just like so many topics. You don't have to like look back and figure out like, oh, where are my notes on this and all this stuff. So again, you can use code ATCornerStudent to get 10% off that monthly subscription. There's also a free trial if you're interested in that. We also do other episodes here on AT Corner other than BOC episodes. So we do story episodes where we take stories from real life athletic trainers and we talk about a certain topic and we kind of bring our expertise all together on one thing. Randy heads our education episodes where he reads a ton of research articles. I don't know how he does it because I just spent so long putting together this episode and he does it all the time for the CEU episodes, but he puts together so much that he's read and they're for CEUs. So the latest 5 are free. So remember that once you pass your BOC and become certified, there's still something here for you. And it's a reporting year for those of you who are now certified listening. So make sure you check out those CEUs. And then lastly, we do interviews, which we actually have a couple more coming up. We are so excited. We have so many this year.
That's
which
awesome.
Is so exciting. So much to look forward to. And thank you for tuning in. I think that's all I have.
Thank you for helping us showcase athletic training behind the tape. Bye.